Good afternoon to everybody east of Thunder Bay, and good morning to the west. Welcome to the Canadian Patient Safety Institute's 6-part webinar series focused on knowledge translation and implementation science. My name is Christopher Thrall. I'm the Communications Officer with CPSI, and I will be your MC for the webinar. I would like to welcome you on behalf of our web host, Tricia Swartz, CPSI Patient Safety Improvement Lead, and our technical host, CPSI Project Coordinator, Monique Thibodeau. Our call today is the second of 6 in this informative series, today's topic being knowledge translation and synthesis. While this series is best enjoyed as a whole, of course, you're always welcome to attend any one, several, or all 6 webinars in the series. If you miss a webinar and want to catch up, please know that all are recorded and available on our website the week following their webcast date. It gives me and CPSI inestimable pleasure to introduce our speaker for this webinar, Dr. Jeremy Grimshaw. Dr. Grimshaw received a Bachelor of Medicine, Bachelor of Surgery degree from the University of Edinburgh in the United Kingdom. He trained as a family physician prior to undertaking a PhD in health services research at the University of Aberdeen. He moved to Canada in 2002. Dr. Grimshaw's research focuses on the evaluation of interventions to disseminate and implement evidence-based practice. Jeremy is a senior scientist in the Clinical Epidemiology program at the Ottawa Hospital Research Institute, a full professor in the Department of Medicine at the University of Ottawa, and a Tier 1 Canada Research Chair in Health Knowledge Transfer and Uptake. He is a corresponding fellow as well of the Royal Society of Edinburgh. Dr. Grimshaw will talk for approximately 40 minutes, allowing us 15 minutes at the end for questions and conversation. Please write your questions and comments in the question and answer box on the right of the screen there, or the chat box, and they will be compiled and provided to our speaker at the end of the call. If you run into IT difficulties, please connect with us in either the chat or question and answer box, and we would be happy to assist. Without further ado, CPSI is delighted to welcome our speaker for today, Dr. Jeremy Grimshaw.
Thanks, Christopher. So this is Jeremy Grimshaw, and welcome to everyone who's joining us today for this second seminar in the CPSI webinar series looking at how knowledge translation and implementation science might help and support safety improvement programs in hospitals and organizations across Canada. I've got a couple of slides which just give some background to the whole series, and then we'll get on with today's seminar. This is the real reason why we're organizing this seminar series with CPSI, and that was if we're thinking about sort of basically trying to implement patient safety practices or programs in hospitals, then we need people to basically change their behaviors, recognizing that often people are working in complex, ordered chaos, healthcare environments. And so if we do want to think about implementation and changing people's behaviors, there is a body of knowledge and body of evidence that we can access that will allow or that will help us to hopefully be more successful in our approaches. And what we're trying to do in this webinar series is provide an introduction to some of these behavioral approaches and why they might be helpful to you in your local setting. As Christopher said, this is one of 6 webinars. We had the Introduction to KT and Implementation Science last week, and that was, or a couple of weeks ago, that was a general introduction to the field. Today we're going to talk about knowledge creation and synthesis, and the key messages coming out of today are that actually there's a lot of knowledge and evidence that we should be using if we want to think about not only what patient safety practices we want to encourage in our environment, but also how we can implement them to make sure that we maximize their impact. This is probably a slightly more academic session today, whereas I think as we move forward from here, we're going to be much more sort of grounded in terms of the practical and problem-solving issues that many of the participants on the call will face. So the next webinar, which I think is next week, is who needs to do what differently to program implementation. Then 2 webinars on how do we identify barriers and enablers, and then thinking about how we develop and evaluate our change programs that address these. So as I said, today we want to really focus on knowledge creation and synthesis. Last time we gave you this model. This is Ian Graham's model, which is called the knowledge to action framework, and this is a very prominent model in healthcare. It basically has in the center what we call the knowledge creation.
Do you want me?
Hello. Okay, I'll keep going. Sorry, someone. I'm assuming people can hear me. It's got in the center. It's got a knowledge creation funnel, which is what we'll largely talk about today, and that relates to what knowledge should inform our change processes. But the outer action cycle then says what should healthcare organizations do in a systematic way if they're trying to increase the likelihood that their change processes will have an effect. And over the subsequent webinars, we'll actually talk in more detail about some aspects of the action cycle. But today, I'm going to largely focus on the knowledge creation funnel. And basically this, as I said before, this is about what information can we use that might be helpful for our planning purposes. And the knowledge creation funnel, the inverted base is knowledge inquiry. And these are the individual research studies that are published in journals around the world. And there are tens of thousands, if not millions of these published, or hundreds of thousands published each year. And one of the challenges about these primary studies is that they're very rarely sufficient to warrant a practice or policy change. It's very hard to do the perfect study, and normally studies will be done away from our practice context, and so we always have to make judgments about whether study findings might apply in our practice context. And so it's very rare that you'd say that any individual one study would actually be sufficient, that we should now change what we do. In general, what we would like to do is to look at the global evidence base within for a particular question. So you may identify an individual study that talks about how we might improve closed-loop communication in, say, operating rooms. But what would be important is to actually sort of say, okay, well, how many other studies are there around the world? And when we look at all the studies together, do they either support this practice, or do they suggest that it's not worth us trying to do? So individual studies might be misleading. We need to think about studies in the context of the global evidence base, and this is the next two sort of elements of the knowledge creation funnel, focusing on knowledge synthesis and knowledge tools and products, and that's what I'll talk about for the rest of the time. So when we think about knowledge synthesis, we're talking about reviews of a clearly formulated question that uses explicit methods to identify, select, and critically appraise the relevant research and collect and analyze data from the studies that are included in the review. So it's basically sort of saying we can use scientific approaches to sort of look at the global evidence and work out what the key messages are for us in our own sort of setting. This is sort of basically an idea about what systematic reviews involve. So first of all, state the objectives of the research. What's the question that you're interested in? Do closed-loop communication training interventions increase the use of closed-loop communication and reduce communication errors? Then, if that's your question, define your eligibility criteria for studies to include in. What sort of studies do we want to look at? Well, we might want to look at sort of basically before-after studies. If we introduce closed-loop communication training, does that lead to improvements? But we might also want to sort of say, actually, what we'd like to look is see if this is tested, say, in randomized controlled trials across multiple studies. So working out which studies are going to give you the best answer to the question you've got, then try and identify all potentially eligible studies, assess these studies against your eligibility criteria, pull out your data set, then analyze it, and then prepare a structured report for the research. The reason I like this is it's a very generic description of just how science works. Ask your question, think about what methods will most reliably address your question, conduct your study using the best methods available, and then kind of report what you've got. And here, when we do a systematic review, instead of our units of observation being, say, an animal or an organ or individual society, we're trying to draw conclusions from bodies of evidence. In healthcare, systematic reviews were largely used initially to look at the effectiveness of healthcare interventions. Does deep vein thromboprophylaxis reduce the incidence of deep vein thrombosis? But increasingly now we're using the same approaches to look at diagnostic and screening tests, studies looking at determinants of health, epidemiological studies, health system issues. And also there's now been a significant growth in the area of systematic reviews of qualitative methods that, for example, could allow us to look at studies that have looked at consumers' experiences of healthcare. So, you know, we can use this method to ask virtually any type of or address any type of question. Sometimes when we're doing a systematic review, we can also do a meta-analysis. I'm going to talk about this because meta-analysis is a very powerful tool that allows us to draw conclusions across bodies of evidence. But a meta-analysis is largely a method of analysis of the results in a systematic review. So it's a use of statistical techniques in a systematic review to integrate the results of the included studies. So before we start, I'm not going to ask you all to answer this, but you know, I want to ask you a question about, do you wear support stockings when traveling on long-haul flights? So if you're going on holiday or you're traveling for business, do you wear support stockings or you just wear your normal socks or tights and shoes? My guess is a lot of us do long-haul travel, so this is potentially quite personal. This is a meta-analysis that actually summarizes all the evidence that we know about whether wearing compression stockings will prevent deep vein thrombosis in airline passengers. And we call this way of presenting information a forest plot. And I'm going to take a little bit of time just to walk you through it, because once you understand the forest plot, it becomes very easy to quickly read these, and they provide a huge amount of information. So just to sort of step you to how this works. This is basically the title of the review. So the review is compression stockings for preventing deep vein thrombosis in airline passengers. And this set of analyses is looking about the effects of wearing stockings versus not wearing stockings. So basically randomized controlled trials where people randomized to wear a stocking or not. And the outcome here is whether people had symptomless deep vein thrombosis. So we're probably really interested in whether people had symptoms of deep vein thrombosis or pulmonary embolism, which could be a major adverse event. But what this has looked at is to sort of say, when people have worn stockings, does it reduce the number of symptomless deep vein thrombosis, some of which will go on to have symptoms, many of which will not. But it's still an important outcome. So what you have on the left-hand side of the slide is basically an identifier for each individual study. So this tells us that there were about 9 studies, sorry, that have examined this question. Each study is given a specific sort of a label. These next 2 boxes tell us how many people were randomized in each study. So if you look at LONFLIT-2, about 411 individuals are randomized to wear stockings. And 1 out of those 411 people got a deep vein thrombosis. 422 people were randomized to receive no stockings, so just to wear whatever they'd normally wear on the plane. And 19 out of 422 of those patients received or had a deep vein thrombosis. And as you go down, what you can see is that the studies varied in their size. So LONFLIT-4 only randomized about 124 patients, whereas LONFLIT-5 randomized 358 patients. And you can see that the incidence of these events were relatively rare. And in most studies, we may not be able to actually identify whether a significant increase in deep vein thrombosis occurred. This is a very important set of boxes. What you have in the vertical box going down, you can see there's a line that cuts across this, a gray line. And this is a line of no effect. And basically, if our study results sat on that line of no effect, it would suggest that the intervention had not had any difference between the intervention or control. At the top box, which talks about odds ratio, tells you the effect size that was used, and in the bottom you get some idea about the scale of the effect size, but also what the direction of the effect is. So this tells us that if basically studies were largely situated on towards the right of the no effect line, it would be the results would be saying no stockings seem to be superior. But if they're on the left of the no effect line, it would suggest that stockings are beneficial. And then these are the results for each study. So in the left-hand box, you've got a graphical representation of each study. And the central blue square is the effect size. It tells us what was the observed effect within this. And the two lines radiating on either side give us some idea about the statistical certainty around that effect size. And when you have, as you do with Lonflit 4, that your confidence intervals overlap the no effect line, it would suggest that the finding in this study was not statistically significant. So in other words, if we're just only looking at this study, we would say, well, it's not clear to us whether the use of deep vein of stockings was protective or not. If you look at Lonflit 2, you can see here that the confidence intervals are some way away from the no effect line. So that suggests that in this study, the individual study, there was a statistically significant improvement. If you look at the right-hand box, this tells you the observed effect in each study. So again, if you look at Lonflit 2, it suggests that there was a 95% reduction in the odds of having a deep vein thrombosis if you wore compression stockings. And what you'll observe is that in the vast majority of these studies, the point estimate, the blue boxes, were to the left of the no effect line, which suggests that in general they suggest that the interventions might be protective, but only two of them individually actually reached statistical significance. And then finally, this is a sort of summary of all of the results. So what it tells you is across all of these 9 studies, there were about 2,600 patients randomized, and the black diamond represents the effect size across all of the studies. And it would suggest, if you look at the odds ratio at the right-hand side, that if you wear compression stockings, you reduce your risk of symptomless deep vein thrombosis by about 90% as a result of wearing the stocking. So I've taken some time to go through that. What I might do, Chris, is just pause here and see if there's any immediate questions people might have about the interpretation of forest plots. As I said, these are ways of presenting a lot of information in a very compressed way, and if you get to read them, in particular, largely looking to see what the overall effect was represented by the black diamond at the bottom of the forest plot, you can often, basically very rapidly assess whether a treatment is beneficial or harmful. So maybe, Chris, we could ask people whether there's any immediate questions. I'll have a sip of water. If there's not, we can just continue.
You bet. Thank you very much, Jeremy. I do have one question that's come in here. I'm definitely wearing compression stockings on my long-haul flights from now on, but the question is from Joanne, who works in pediatric rehabilitation. Within studies, interventions are complex, and even interventions called by the same name are actually quite heterogeneous. Would you recommend navigating these challenges for synthesis? And, for example, do you know of any resources available?
So it's a great question. I mean, the fundamental idea behind systematic reviews and meta-analysis is that you would anticipate that the interventions would have a similar directional effect. You may have variability in how the interventions were delivered or where they were delivered, but in general, we'd expect all of the interventions to show some benefit, harm, or largely to show no effect. So you can do a systematic review where you say, well, largely ignore the complexity and just see if there's a directional effect. And this is not a complex intervention as the ones that Joanna is mentioning, but you can see that when we look at this example, everything's going in the same direction. So even if there's sort of minor variance in, say, what stockings people used or whatever, in general, it probably doesn't matter. So you can do a systematic review where you do look at just complex interventions, say, in general, is there a directional effect? But I think what Joanna is probably getting to is that we also often want to know, well, what will make it more likely to be successful? Where will we get the best results? So what are the elements of the program that would allow you to judge sort of basically if we deliver our program this way as opposed to that way, it's more likely to be successful. And there's a growing body of information about how to do these reviews of complex interventions. The Cochrane collaboration, which I mentioned, has a lot of experience, and the Cochrane Handbook talks about this. There's also been a number of sort of series on systematic reviews of complex interventions. And maybe Chris and Tricia, if you prompt me, what I can do is provide a link to those resources so that people can follow up with them if they want to.
Terrific. We'll maybe try to include that in the follow-up email after the webinar. So thank you very much for that then, Dr. Grimshaw. I don't have any other outstanding questions, so please feel free to continue.
I'll keep going.
Thank you.
And, as you said, Chris, I now wear sport stockings when traveling on long-haul flights. It seems to me that it's basically, it actually reduces swelling in general. They're not uncomfortable, and it will reduce my risk of having a deep vein thrombosis. I work in a hospital that's got a lot of thrombosis specialists, and I really fear that if I was on a long-haul flight and I got a deep vein thrombosis and was admitted, and they asked me whether I was wearing support stockings, and I said no, that they would beat me up. So I am convinced by this evidence that this is worthwhile. Doing this as we move forward.
Fantastic. Thanks, Dr. Grimshaw.
Okay, so that was a question, that was an example of where knowledge synthesis might be relevant to understanding, basically what, say, clinical intervention we should provide. And you can also do systematic reviews of what change interventions you can provide. But also, knowledge syntheses can be used to look at different aspects of the action cycle. So one of the key steps that we'll spend a lot of time on is assessing barriers to knowledge use. And we've got 2 seminars coming up that will look at that. But actually, we've got an increasing body of evidence where people have done research studies that have tried to assess what the barriers are to knowledge use, and they might help us to make sense of what the problems we face in our own setting. And as one example of this, we've been working with colleagues in the UK who are interested in basically understanding what are the barriers and facilitators for people living with diabetes to receive eye screening. So we know that eye screening is an effective way to prevent diabetic retinopathy, which is the most common cause of blindness, parental cause of blindness in adults. But we also know that in many settings, people are not accessing sort of existing screening programs. So, for example, I think in Ontario, probably between 30 to 40% of patients or people living with diabetes don't get their eye screened very regularly. So if we try to plan a change process to say, well, what can we do to better involve or get people to be involved in screening, one of the things we could do is sort of say, well, is there any research evidence out there that might help inform our thinking? And when we went out and looked at this, we found 69 primary studies that had already looked at whether or what the barriers and facilitators are for people living with diabetes who to receive eye screening. And there were 6 what I'm going to call theoretical domains. In subsequent webinars, we'll give you more information about this. But 6 main drivers of whether people got screening or not. One was the environmental context and resources, so this would be things like ease of access to the program, whether there's parking, whether there's childcare facilities, or whether individuals can get time off work. Social influences, whether people are important to the individual person thinks they should do this. Knowledge, whether people actually understand that screening can prevent adult blindness and people living with diabetes are at high risk of that. Memory, attention, decision-making processes. I have to remember every year to make an appointment to get this done. And if no one's prompting me, that might be difficult. Beliefs about consequences. I don't think this is this is relevant to me. I have very good control of my diabetes, so I don't think I'm at risk of eye conditions. Or the emotions. I actually I'm a bit scared of the idea I might have eye problems. I don't want to find out about it. So by doing a systematic review of the barriers, we could get a sense of what were the kind of key issues the global literature tells us, which we could then supplement to to sort of think about, do we need to collect more information locally, or is there enough here to work through? And also, I've not gone through it, but there were specific barriers identified in each of these levels. So it gave us specific ideas about what the problems might be. So we can use knowledge syntheses across a broad range of the knowledge to action cycle to inform what we do. Whoop, can I? Yep, okay. We can also use knowledge syntheses to sort of say, what do we know about the effects of different change processes or change programs? And so there is a group in the Cochrane collaboration called the Cochrane Effective Practices Organization Care Group. And this does systematic reviews of interventions to improve healthcare systems and healthcare delivery. And they include professional, financial, organizational, and regulatory interventions. And to give you an idea about the work to date, this is actually now an out-of-date slide. There's probably about more than 125 reviews have been done, and there's 60 ongoing. And the type of interventions that they look at are, does audience feedback lead to improvements in professional practice? Do computerized reminders lead to improvements in professional practice? What happens if we ask lay workers to get involved in maternal and child health? So a broad range of areas that often, when we're thinking about what intervention we want to use as part of our change process, we might be considering. Financial interventions are probably less relevant at an organization level, but certainly relevant at the health system level. What happens if we change the way in which we pay healthcare professionals, or we change co-payment arrangements with patients? So there's a lot of information out there that's sitting there that we can make use of. And my guess is that we may not be aware of all these resources, and we may not use them. And what often happens then is that we largely, we may choose to do interventions that are not going to be effective, or not going to be most effective for the type of problems we're trying to deal with. So we have a lot of information out there that we should be trying to use. Here's some examples from the findings of various EPOC reviews, just so you get some idea about what the what results we find. So there have been 140 trials comparing performance feedback versus control. And we find in general that they tend to improve quality of care. They lead to an absolute improvement of about 4% in performance. So in other words, if your baseline performance was about 4%, it was about 50%, after an audit feedback intervention, we might anticipate that it'll get to 54%. But also, if you look at the interquartile range, there's a very wide range of effects that we've seen. So a quarter of studies found that the effect, the benefit was less than 0.5% improvement. But 16% basically we observed for 25% we observed an effect larger than 16% from using performance feedback. And so the issue for us then is, well, under what circumstances are we going to get large effects and hopefully get sort of 8 to 10% improvement? And can we use that when we're thinking about how to choose our intervention? Again, educational meetings, 81 trials, 6% absolute improvement in quartile range, plus 3 to 15%. So these are two areas where we have a lot of information already that might support our choice of interventions as we move forward. But also note that Financial incentives. This is really the whole pay-for-performance movement, which has been very dominant in the US and to some extent in Canada. By 2011, there are only 3 randomized controlled trials. There's very little information about whether it's likely to be beneficial or not. Since then, there's more trials come out, but there's still probably less than 20. But again, what we're finding from that literature is that you're getting about a 6 or 7% improvement with these pay-for-performance interventions. And then look at hand hygiene. I mean, hand hygiene is a major safety concern. But by 2010, when Diana Gould did her review, she only found 1 trial actually exploring or looking to see whether an intervention led to improvements in hand hygiene. Again, there's been a lot more. This has been recently updated, so if you want to know where we are now, you might want to look at the Cochrane Library. But I wanted to put this up to flag up, in some areas we have lots of evidence, and we have lots of evidence about what works, and we should be trying to use that. In other areas, we have much less evidence. It doesn't mean we shouldn't use those interventions, but we should be aware that the evidence base is weak and maybe build a better evaluation around this. If we talk about the Cochrane Audit and Feedback Review, as I've already said, there's about 140 trials, about 4% absolute improvement, interquartile range 0.5 to 1% to 16%. We were able in this review also to look at what was associated with a larger improvement. So you got a larger improvement if baseline compliance was low. So if you're starting off with an area where, say, performance is at 30%, you'll get a larger effect than if performance is at 80 or 90%. If the source was a supervisor or colleagues, if it's provided more than once, if it's delivered in both verbal and written formats, and if it included both explicit targets and an action plan. So if you're planning an audit and feedback intervention or performance feedback intervention as part of your improvement process, these are the things you might want to factor in. How do we sort of make sure, we will commit to giving it more than once. We will commit to sort of basically this being delivered through a supervisor or colleagues. And we'll structure this so that we're providing very explicit targets so people can think through what the implications of this are for them. So by doing this review, rather than starting off with a blank sheet of paper about we've got to do some performance feedback, it gives you signals about, well, if we want to do it, first of all, we're likely to get improvements, but also we need to think about how we design and deliver this because that will increase the likelihood we're going to get a larger effect. One of the issues is that not all systematic reviews are equal. So systematic reviews and other knowledge tools are variable quality. And so, if you're going to use systematic reviews, you need to assess the quality and local applicability of the systematic review. So you want to have a sense in terms of, was this well done or was it not so well done? Fortunately, we have a number of tools that actually allow people to do this. So the AMSTAR tool has been developed by Bev Shea and colleagues across Canada and elsewhere. Is a fairly easy to use appraisal tool for looking at a systematic review to say, is this a well-conducted or less well-conducted review? So here I'm just sort of saying we need to be a little bit cautious and not just assume because there's a review that we can trust the findings. We need to be sort of critical users of the evidence. That can sometimes be off-putting, but we do have groups like the Cochrane Collaboration, and I've been involved in Cochrane for over 20 years, whose reviews in general do perform well on AMSTAR. And so if you want to, if you wanted to say, let's go to a place where we're pretty confident about the quality, you could easily go to Cochrane, and there's a lot of reviews done by EPOC relevant to patient safety. And currently in Cochrane, there's over 7,500 systematic reviews and details of about 2,500 ongoing. But there's also other resources, made in Canada resources that could be particularly helpful for you. And this is a resource that's developed by John Lavis at McMaster University called Health Systems Evidence. And if you go to Health Systems Evidence, this is the screen you get to. And it basically includes evidence syntheses, about 4 types of decisions. Decisions about how care is made, how care is paid for, how care is organized, and how change can be brought about. So I'm going to focus on this last area. If you click on this hypertext link at the bottom, what you get is there are 14,000 documents that tell us a little bit about how different interventions might work. And you can see on the left-hand screen, there's a list of all of the potential interventions, some of which are targeting our consumers, some of which are targeting professionals. And if we use audit and feedback as the example, and we click on audit and feedback, you can see there are 793 reviews and synthesis documents relevant to audit and feedback. That sounds like it's pretty daunting, but if you then click where it says click here to review the 793 results, this is what you actually get, and you get basically a list of reviews, and it's ordered by both the year of the last update and also the quality of reviews. And so this allows you to start to sort of say, well, which of these reviews from the title looks like it might be sensible, and it provides a lot of additional information. So let's say we wanted to, the third entry down here is the Cochrane review, and if we clicked on that, what you then get, and sorry, it's not great on my screen, but some of the information provided was, when was the last year that the literature was searched? So the Cochrane review was actually published in 2012, but it's last searched in 2010. So that might give you some sense about, well, is this up to date? Is it, are we confident in the results? Is it likely that the evidence has changed a lot in the last now 6 or 7 years? We have to get on and update that. It also gives you the quality rating. So this scores 9 out of 11 using AmStar. So this is the initial version of AmStar. And as a rule of thumb, in general, if your review scores 7 or more, it's pretty high quality, likely trustworthy. If it scores 3 or less, then it's actually pretty ropey and probably not worth looking at. And if it scores between 4 and 7, you need to be cautious, but it may be worthwhile looking at. So fairly quickly, you could get a sense about which are the most up-to-date and the highest quality reviews that I'm going to focus on to make sense. It also, down this arm, down the left-hand side, identifies basically a number of friendly summaries where people have taken the review and summarized it in a way that means you don't have to go through necessarily the full review. And if you clicked on that, you'd get to basically the Cochrane lay summary that would summarize what the review says. And this is a fairly quick way, again, of not having to go through a long review, but getting an immediate view about sort of what might be potentially helpful. And finally, you might want to sort of say, well, how many studies have been done in Canada? And what John and colleagues have done is that they've actually also then identified which of these studies are done in Canada. And if you click on these, it'll take you to the PubMed view or PubMed details of that study. So what you've got, what John and colleagues in Health Systems Evans are doing are trying to make this easy for you to access this information. So that, if you actually sort of say, okay, I'm interested in looking at, how we improve practice, I want to know the effects of audit and feedback or academic detailing, you can click through to find the most up-to-date and highest quality reviews. You can click through to find out, has someone provided a user-friendly summary for me? And you can also click through to say, are there any Canadian studies that I might want to look at in some detail? And I think we're going to see an increasing number of these kind of resources which will be helpful for people in healthcare systems and healthcare organizations trying to plan policy and practice change processes. The final bit, just coming back to the knowledge interaction or the knowledge creation funnel, are knowledge tools and products. And what we mean here are things like clinical practice guidelines for clinicians, decision aids for patients, policy briefs for managers and decision makers. And one of the reasons that this is an inverted funnel is the idea is as you go from knowledge inquiry to knowledge synthesis to knowledge tools, you're starting to basically tailor the knowledge to the needs of the end user. So we'd argue that someone in the Ministry of Health and Long-Term Care in Ontario does not necessarily have to go immediately to a 100-page review, but actually might go to a policy brief which would give the highlight summaries of these individual reviews. If you're a patient trying to make decisions about whether you want, say, surgery for your knee arthritis, rather than going through a lot of reviews, if you can find a good decision aid that summarizes the evidence in a user-friendly way, that's going to be helpful for you. And also, if you're a clinician, then instead of going through 10 clinical practice guidelines about how to avoid deep vein thrombosis if you're on a long-term flight, if there's a guideline there, you can actually sort of basically get all the information from that. And so again, particularly, I think probably more for clinical audiences, but yeah, these knowledge tools are very helpful thinking about what the clinical care we should be providing. And this slide very briefly just highlights again that guidelines are not all equally trustworthy or credible, and the AGREE instrument is an appraisal instrument that you can use to basically try and assess whether a guideline is likely trustworthy or not. So if you have a clinician who, for example, comes and brings a guideline, his latest guideline from the Canadian Big Sore Toe Society, you might ask sort of basically, okay, well, how is it developed, and can we use AGREE to see whether this is a guideline that we think is trustworthy before we think about changing a particularly sort of clinical practice in our hospital. So I'm coming to the end, and hopefully what I've tried to do so far in this is to sort of highlight how evidence could be useful for you when you're thinking about basically changing practice and how to change practice. There's implicit within this has been a kind of an assumption that you as part of the safety teams in your hospital might be the people doing this, but I think increasingly we should also be sort of saying, well, how can our hospital basically facilitate use of evidence by the quality and safety group in the hospital, by clinicians in the hospital, by managers in the hospital. So in other words, we should be thinking about what knowledge infrastructure do we need to make sure that knowledge is being moved around the organization in an effective way. So if we are, for example, interested in improving communication in operating rooms, one of the, that's going to be on our agenda for the next 3 to 5 years. Is there a way in our organization that someone is trying to find any evidence that's coming out and pushing it out to the right people in the organization so they're being kept up to date with the research evidence? So instead of putting all the weight on the shoulders of the individual, let's think about at a system level, what can our hospital or our healthcare system do to make it easy for people to actually have access to the knowledge. And there's a very nice tool that's been developed by the Canadian Foundation for Healthcare Improvement that basically sort of, the idea behind this tool is that you'd sit with colleagues in your organization and just think through, to what extent is our organization actually systematizing and institutionalizing how we can access and use evidence that will make it easier for staff and for clinical staff to basically be, to have access to knowledge and evidence in a systematic way. And you might want to look at this, and certainly for those of you who are in sort of safety and quality groups in hospitals, you might want to think about, well, what can we do in our hospital that will increase the likelihood that we are aware of new evidence that becomes available and we can use it to inform our future processes as we move forward. So my final slide is, this feels as though it's a little bit of a sidebar to the main action of the webinar series that, we're going to talk a lot more about, okay, well, how can we actually change practice in the subsequent ones, but that evidence can support each step of the knowledge to action cycle. We can use evidence about what the problem is. We can use evidence about, what the drivers of the problem are. We can use evidence about how we can change practice, and we should be trying to use that evidence base rather than starting with a blank sheet each time ourselves. So in general, knowledge synthesis tools could inform improvement activities like the clinical issue, what should we be doing, or the improvement issue. And increasingly, there are evidence supports like health systems evidence, or if you're in public health practice like health evidence, which is run by Maureen Dobbins at McMaster, and that actually makes it easy for you. But I think you can also in your organization say, are there ways in which we can make it systematize it so it's not down to the individual when it's 7 o'clock on a Friday evening when they should be at home having supper with their family to sort of try and find the evidence themselves, but we're feeding evidence out to support the organization. And that was it. I've highlighted a number of the key resources there, and following on from Joanna's question earlier on, we'll provide some additional resources about systematic use of complex interventions. So Chris, I'll hand back to you now.
Beautiful. Thanks so much, Jeremy. That was a terrific presentation. I personally really enjoyed the sort of audit and feedback improvement tips. So we have received a few questions from the chat box, however, and going back to a topic that raised some interest earlier, Janice was wondering how many hours would be considered a long-haul flight for compression socks?
That's a really good question, and I will go back and find out.
Perfect.
I don't know. My rule of thumb is if I'm flying to Europe or I'm flying from BC, I definitely do this. Alberta, from Ontario to Alberta, it's marginal. But I don't know. But if you are, certainly I would anticipate sort of 5 or 6 hours would be my rule of thumb. But if there's any clinical experts in the on the call who disagree with that, please let me know. And I will ask, I'll go back to the review and have a look at it. And if I find that answer, I'll post it to you, Chris.
Beautiful. Well, in that case, we'll just establish a hard and fast rule that Dr. Grimshaw says 5 hours plus. Another question we received is how in-depth or exhaustive does the knowledge inquiry or analysis process need to be? Many organizations don't have access to librarian services or direct access to researchers, so how can they do this type of work at a more local or smaller scale level?
That's a really good question, and I mean, there's some of the responses would be, I don't think in a local organization you should be doing a systematic review. You should be trying to find existing systematic reviews that are, high quality. And so that's why I think something like health systems evidence is potentially a remarkable, useful tool, because first of all, they've done all the searching. They've tried to find everything that's relevant. They then have sort of also rated these according, these are high quality, these are up to date or not up to date. And so my sense would be that, if you went to health systems evidence, you could start off with that as your initial filter, and probably not go down more than sort of the first few screens to get a sense about to get the identify which are the most high quality reviews, and then you can look to see if they're up to date. That access to the plain language summaries is also really helpful because even though I'm a very experienced scientist and systematic reviewer, the first time I go to a Cochrane review, I will look at the plain language summary, and it often gives me the best sense of what the evidence base will tell me. And you can use that as a filter if it doesn't seem very relevant to me, or actually it looks like it's really relevant. I'll actually try and pull down the full review and get access to that. So I think you should be trying to find these short cuts. What you're trying to do with this is just help you think about this in a smarter way. So if you take the audit and feedback example, and we could certainly do a lot more talk on that because there's a huge amount of additional information we could provide about that. Rather than sort of sitting down and sort of saying, where should my starting point be? Do we think it will work or don't we think it will work? How do we deliver it? What do we provide a graph? Do we not? It gives you some background information to allow you to think about this in a smarter way. You're still going to have to make a whole range of judgments that what will work in my setting for our clinical group for this practice, but help you think about this in a smarter way. So if you do some initial sort of look into the research evidence, if you don't find anything that's very helpful, then do whatever you're going to do. But if you find, I suspect increasingly, you will find that there's information out there that is helpful for your thinking. But you don't necessarily have to be hugely exhaustive, particularly given your resources. But you could think about other ways in which, if you do have any access to a library or librarians in your sort of setting, I often see modern day librarians as being the white knights in shining armor sort of riding over the hill, because they are really trained to sort of make it easy for you to access information. So if you're in a smaller hospital and you don't have access to that, it may be that there's kind of ways in which you can link to your referral hospital, say, we're really interested in trying to learn more about this, could you help us find this through? So you can do it independently through health systems evidence. If you've got people, if you've got a librarian or access to medical library services in anywhere, use a librarian as well, because they will have a huge amount of experience that they can bring to help.
Perfect. Thanks so much. We did have a comment again on the SOX. Donna says that the Cochrane review says that studies included flights of 4 hours or more, so we might adjust that by an hour. I know we keep on coming back to it, but people are very interested.
Next time I fly to Alberta, I'll wear my thank you for Donna.
Yep, probably wise. I had another one from the chat room. You touched on the effectiveness of interventions in overcoming barriers. On the flip side of that, of the 6 theoretical domains and barriers that you discussed, is there a hierarchy of impact? Have you found that for the identified barriers? Is one identified barrier more challenging or easier than another to overcome?
So this issue is precisely what we'll start to cover off in the next
gotcha.
3 or 4
so
webinars.
Wait till next week is what you're saying?
Well,
tune in next week, when?
Probably the week after, or the one after next. But you have to do the next one so you understand the one after that. I mean, the issue is that it seems to be very specific to the kind of the practice that you're dealing with.
Of course.
So, for example, we've looked at sort of with Choosing Wisely Canada at why patients who have ambulatory surgery who are low risk are getting routine tests, and the things that come out of there are in particular sort of social role and responsibility, social influence, and external environment. But if we also look at, say, why are patients with back pain having too much imaging, different things come through. It's often about sort of views about patient demand, views about sort of uncertainty about how to negotiate with patients not to do that. And so to some extent, what we'll be doing in the rest of the series is starting to say, how do you get this fit in terms of the problem to your intervention? What we do find is normally we can service many, many more barriers than we could possibly address. And so we have to go through a prioritization process to say, okay, in our setting for this sort of group, for this problem, which of these are most compelling as barriers that we think if we don't address those, we're not going to get traction. But I'd hope, I mean, I think you could probably ask the same question in each of the next 4 of the 4 webinars, and each time we'll kind of probably further iterate the answer.
Excellent. Thank you, Jeremy. I do have 2 more questions that remain, and then we'll be able to wrap this up. Thank you again so much. But from Joanne, what is your perspective on conducting a rapid review when systematic reviews on your topic don't exist? Are there other shortcuts you can suggest?
Yeah, so there's an increasing interest in rapid reviews, which would take the overarching, that original model that I suggested about a systematic review, but try and find ways of having shortcuts around that. So, for example, you may only search Medline. You may only have one person screening the results or data abstracting. You may not do a meta-analysis. You may do a more descriptive summary. So there's this idea about rapid syntheses. One of the issues is in most settings now, or for many areas, if you look, there are existing systematic reviews, and we've certainly, but you can use systematic reviews as the entry into the rapid review. So instead of sort of saying, we'll go back to the primary studies, we'll actually do a rapid review of the systematic reviews. So we might look at the top 6 highest quality reviews of audience feedback and look across those in a reasonable way. And we did do, again, if you remind me, Chris, we ran a rapid review service for the Champlain regional, LIN, the local regional health authority here, where in general we were able to go back to largely systematic reviews, but we had a formal process about how to do that, and we could make that reference available if people wanted to look at it. So the answer is that I think if you look, you'll probably find in many areas there's more systematic reviews than we think, but you can still do that kind of rapid synthesis group or summarizing the findings from a group of systematic reviews as your evidence input, and that's often going to be helpful because it allows you to probably think through more carefully, my context, the particular issues that we're aware of here.
Sure. That's excellent. And I guess just the last sort of follow-up question for that is, are most of these resources free or open to access or relatively reasonably priced or within a convenient budget amount? What kind of costs are we looking at for these resources?
Okay, so health systems evidence is free. You have to register. But what health systems evidence will do is it won't necessarily, it'll only allow you to go to the review itself if the review is open access. So you'll get everything else, the summaries, other things, but if the review was, say, published in JAMA and it wasn't an open access, unfortunately you won't be able to get, they'll only take you as far as the paywall.
Of course.
But increasingly you'll find these resources are available. So in the Cochrane Library, that is on a subscription basis, but what Cochrane makes available is any review is made open access after 12 months. So for the vast majority of Cochrane reviews, you're going to find that they're open access for you within that. So as a starting point, I think something like Health Systems Evidence, which is free and an amazing resource, it might give you enough, without having to go back to the review. If you have to go back to the review, it'll allow you to work out whether it's behind a paywall or not, and then you can decide, is this something we want to do? We might find that the next reference down isn't behind a paywall and looks just as good. I think I would sort of say, use these free resources as much as possible, and hopefully this will not be, in many cases you'll find that you can get open access. If one of the problems about subscription is you can either pay per paper, and they tend to be, depending on the publisher, a bit pricey. You could subscribe to individual journals. The issue there is that any one individual journal is often not very expensive, but most journals, systematic reviews will only be a small proportion of those. So, but a Cochrane Library, an individual sort of a subscription is relatively modest. I honestly don't know what it is now, but I think it's in the kind of range of depending on how many concurrent users you want. A few $100s if it's only one or two concurrent users. So I think there are undoubtedly this is a barrier. I have argued for a campaign for a long time, and others have, that we should have a national Canadian library that would make a lot of this stuff available, particularly for people working in non-teaching hospital settings or in community settings. We're still fighting that battle. We'll do our best, but you can get a long way into the. You can get a lot of information without having to hit paywalls.
Perfect. Perfect. Thanks so much, Jeremy. I appreciate that. I do see that we're at time, though, so we do want to respectfully thank you, Dr. Grimshaw, for sharing your time and your expertise, and, of course, thanks to all of you for taking the time to attend. We know how busy your day is, and we appreciate you choosing to spend time with the Canadian Patient Safety Institute. Please visit our website for a taped version of the presentation today and to sign up for our next Knowledge Translation and Implementation Science webinar next week, mentioned in today's presentation, featuring both Dr. Jeremy Grimshaw and Dr. Justin Plesseau. They'll be discussing who needs to do what differently to promote implementation. If you wish to sign up for this upcoming webinar, or you want to continue the conversation started in this discussion, please feel free to send us an email. We will forward your comments and any questions you may have had that were unaddressed on to Dr. Grimshaw. You should all receive Monique Thibaudot's follow-up thank you email in your inbox shortly, and you can respond to that. So have a wonderful day, everyone. Thank you again, Dr. Grimshaw, and we hope to see you all again soon.